Hello, my name is Justin Lin. I'm a respiratory therapist. This is Ann Beeson. She's a speech and language pathologist, and we're with the Tracheostomy Home Ventilator Program of Children's Hospital of Wisconsin. We are with Miss Blessing. She is an 11-month-old ventilator-dependent baby who was born at 23 weeks of age. She was hospitalized for the first 205 days of her life, discharged home, came back about 2 months later, and eventually was placed on ECMO and is now tracheostomy and ventilator dependent. We also have with us mom at the same time. So on the ventilator, she is currently on the vent pretty much all the time. She's in SIMV volume control, rate of 8, tidal volume of 75, an I time of 0.4, pressure support of 10, and PEEP of 5. She has recently started to come off of the vent for about 1 hour, 2 times a day, and so we are starting the progression towards getting her off of the ventilator. We are here to perform a speaking valve assessment and evaluation.
And we're going to do that in line with the ventilator. She has a 4.0 cuffless trach at this point. As you can hear, she's quite vocal. Yeah. On cue.
And so as we enter in to do the assessment, obviously we've looked at her baseline vital signs, and at the moment she sits at about 140 for her heart rate, and her oxygen sats maintain right about 98 to 99. And when we do evaluations, we typically try to open up the clothing so we can get a good look at her work of breathing. Resting and comfortably, we don't notice a lot of work of breathing, so we see minimal, if non-existent, retractions for her. So as we do this, we have several pieces of equipment that we'll be using to evaluate her. For us, we have the inline passy-muir speaking valve, and for our circuitry, we also have an adapter that we place in line with an elbowed adapter that we hook up to a manometer so that we're able to measure her transtracheal pressures that might give us an indication if she has an airway obstruction.
And I don't assess or feel any secretions, so I don't think we need to suction her at this point.
Okay. With that, if you want to pre-silence the vent, whoops. Whoops. So we place the valve in line.
So what we're expecting is her voice to be louder and for her to be able to say more sounds per breath.
Yes. We're assessing her transtracheal pressures. They're coming down to her baseline of 5, which is her PEEP level. So basically her pressures would be reading at 0.
And we are looking at how much time we have it on right now. Blah, blah. So we're not seeing any change in her breathing pattern. There's no nasal flaring, no retractions or head bobbing. Her respiratory rate, oxygen, heart rate, all is at her baseline, and she is happy. Right?
Are you happy?
Happy girl? She's looking really good. Yeah. You want to talk to Mama?
Yeah.
Talk to Mama.
Hello. Hi. Hi.
Hi, Mama.
Hi. Hi. What are you saying? What are you saying?
She likes to turn her head towards this left side, so let me see if I can get her a little bit more towards the mama.
Hi.
There she is.
Hey. What are you saying? Can you say hi?
So we're also looking at her ability to manage her secretions and her swallowing. Sometimes we see kids moving their mouth and lips more because they're suddenly aware of those parts of their body. Oh, you took
Well,
it off.
there you go. Say bye-bye. There you go.
Her secretion control was pretty good before we started, so a little bit of pooling of secretions on the side. How are her transtracheal pressures looking?
We're sitting at the baseline 0, well 5, and then we subtract out our PEEP, so we're at 0.
Back, 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 back. Back, 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 back. What's he gonna say?
At this point, when we see that a patient's initially tolerating it very, very well, and we're not seeing any increased work of breathing or any clinical changes in the child, we really start to look at the clock and see how they tolerate the valve over time.
What do you think?
Yeah.
Yeah.
Does her voice sound louder to you?
Yep. Very much so.
Does it sound like it used to, or is it different?
We're close, very close.
You got your fingers in your mouth. Now, Blessing used to be a full oral feeder. She used to love her bottle feeding. And then since she's been here with us, she has not been able to get back to eating by mouth. So she's got her G-tube. She's a little orally averse, so we're working on getting her hands in her mouth more and her pacifier in her bottle. And the speaking valve should help with that. She'll be able to feel what's going on in her mouth better, experience a sense of taste and smell. Will also help her have a stronger cough, to clear more stuff out of her lungs or clear and swallow secretions. So we're hoping that she might need to be suctioned less.
At baseline, she's pretty minimal too. Hi, I see you.
So she's had it on for about 4 minutes. Our goal for our initial assessment is at least 5 minutes.
From that point, as a facility, the evaluating team passes that off to the bedside respiratory therapists, and they then go on an advancing plan all the way up to about 20 minutes BID. At that point, if the child can tolerate that for several days at 20 minutes BID or 2 times a day, we then advance the child to be able to wear the vent as tolerated during the day.
You've got so much to say. I expect that based on the fact that she doesn't look any different from baseline, except she's chatting a lot, that she'll advance pretty fast to using the speaking valve often. I mean, at this point, I would say that we would recommend that she use it whenever she's awake and directly monitored. In our hospital, inpatient, they're connected to lots of different monitors, so we let them be on the speaking valve even if the nurses are just outside the room. But at home, when she goes home, the families have to be directly with her and eyes on them at all times in case there's something happens that you need to intervene quickly and remove the speaking valve and provide whatever interventions you typically would. So we'll start this in the hospital. The RTs will still be in charge of putting it on and taking it off. Well, the nurses can take it off.
Yep.
We'll teach family to put it on and take it off as well. And when she is asleep, then she has to be taken off. So whenever she's awake, she should have it on, so she can have that vocal play and the practice with swallowing and coughing. And
Was she sitting up prior to this hospitalization? So what we find is that when we have the speaking valve, we call it our magic button sometimes, because the speaking valve, it helps build the intrathoracic pressure again, because you can have a closed vocal folds. All the pressure can stay in where it belongs, so that can give you increased spinal control.
I also like to kind of change position so she looks good laying down. I'm going to have her sit up a little bit, see how she does. Pressures are still good, they're not stacking or...
Yep. If the pressures were increasing, we'd anticipate that she were having a difficult time exhaling.
You say hi. You saying hello to everybody? Yeah. You want to close that mouth? What do you think? Hi. You're a cute guy. So still the same. No nasal flaring or head bobbing or use of accessory muscles. No increased work of exhalation at all. She just seems, you got a burp? Super comfortable. Yeah, super comfortable.
You're cute.
So at this point, I think that we can take off the manometer
Absolutely.
and then have Mom practice with putting it on and off.
Can you silence the vent,
So we're
please?
going to silence the vent so it doesn't beep at us.
Thank you. Here we go, ma'am. And then when we do it, we just simply place the two in. So this part is actually the speaking valve. Sorry. This is actually the speaking valve right here. If we try to put that in by itself, it wouldn't fit with the connector. So that's why we just add in this little adapter right here. At home, your adapter might be clear.
Okay.
Just depends on what they offer you.
So always silence it first. Take it on or off whenever you're disconnecting, so it doesn't beep at you. This gets washed once a day with Johnson & Johnson baby shampoo and warm water. We usually recommend that you just take its little container, put it in there, dab out the shampoo, warm water, agitate it, rinse it clear. Hi. Hi.
She wants your attention.
And then if it falls on the floor for some reason, you can wash it more frequently, but at least once a day. Let the nurses know so they can document in our charts when it's been cleaned. And then either let it sit to dry, or if it's you don't want it to have it filled up with water, but it can have a couple of drops in it, it's fine. And put it back on right away.
So the way the valve works is she's going to breathe in through a tracheostomy tube, breathe out through her mouth and her nose. So remember, she still doesn't have her nose that she's breathing in through to get her heat and humidity. So that's why when she is on the speaking valve, she's on the ventilator. So just keep the heat and humidity hooked up to it over there. And no, that way she's getting some heat and humidity with it. If she ever gets nebulizer treatments, which I know she's really not getting them much anymore, but if she does, do not give a neb treatment with it in line.
Really? And then what happened? What happened next?
Okay.
All right.
Wonderful. So
We can be
since
done.
she's all hooked up and
Yeah.
you're here with her,
Sounds
we're
good.
gonna leave
We're
it
gonna
on and we're gonna
did
let her
you-
practice. Yeah, why don't you
Go ahead, you
practice
do it.
taking it in
So
and out?
just take this part off right here.
Yep. And then you can hook the ventilator back up. So take the blue piece out.
Put them back together.
Excellent.
And
And then if you
back
want
it
to,
back on.
yeah, she wants to wear it.
And it only fits one way, so if you have it backwards, it won't work.
Oh, listen to that. As soon as she puts
Immediate.
it in.
All right. Thank you so much for watching. What? You go smile? You smile for the camera?